you want me to use the microphone? Okay, good evening. Don't forget dessert in the back. We're going to get started in a few minutes. So one question everyone might have is, why is there a video camera in the back? I could do a Brian Williams thing because everyone's making fun of him this week. The reality is this is a trial. We want to video and audio tape this with the idea when we did the Schumacher lecture in whatever the date was on that, in April. We want to be able to videotape the Schumacher lecture, and then within Dr. Schumacher's journal, there'll be a page which will describe the lecture, the lecturee, and then there'll be a internet link that'll link them to the actual lecture. So tonight, this is just a trial. You don't have to be on good behavior. This isn't going anywhere. But for the Schumacher lecture, that's a different story. So tonight is the annual CPC. We have two very good cases. Tony Shreve from Penn has worked diligently to put this together, and I'm going to turn the program over to him. Tony?
Thank you. I'd like to welcome you all to our 2015 CPC conference. I'm really happy and excited to introduce two great fellows and two wonderful speakers, discussants. Today, our first case is going to be primary Sjogren's with fever. And then it's going to be presented by Dr. Braden Yellman, who's a first-year fellow at rheumatology fellow at the University of Pennsylvania. And then the discussant is Dr. Humaira Hussain. Pay attention to the spelling of Humaira. Dr. Hussain actually has graduated from the University of Kashmir in India, and then did her internship and residency at her internship at McKeesport at the University of Pittsburgh Medical Center, and did her residency and fellowship training at Hahnemann. She's currently an assistant professor there, and she's the director of the Infusion Center, and also the director of the Quality Improvement in the Division of Rheumatology. And then our second speaker is Dr. Maria Manzor. She's a rheumatology fellow as well at Jefferson. And then our discussant is Dr. Tanya Gonzalez Rivera. She graduated magna cum laude from the University of Puerto Rico. She did her internship and residency there, and then she came to the University of Michigan, where she did her rheumatology training. She was recruited recently to help assist with the lupus clinic at the University of Pennsylvania. Please join me to welcome them. It's going to be exciting. I know those two cases are going to be really exciting and hopefully clinically relevant to you. Thank you. So I'd like to invite Braden.
Thank you very much. So without further ado, we'll get into the case. So we have a 65-year-old female with a past medical history significant for primary Sjogren's syndrome, and she's presenting with 4 to 6 weeks of intermittent fevers, up to 103, as well as waxing and waning mental status. Her fevers were unpredictable in timing, but would occur daily and often several times per day. Her altered mental status would temporally correlate with the fevers and would include both visual and auditory hallucinations, as well as difficulty with orientation to place and to time. She experienced frequent urinary incontinence, often during the episodes of the fevers as well. Her initial laboratory workup on presentation demonstrated mild leukocytosis and moderate transaminitis. And she had an initial ultrasound in the emergency room of her abdomen, and it displayed hepatomegaly. This is just a brief rundown of her past medical history, including her primary Sjogren's syndrome. She was SSA positive, lip biopsy positive, never treated with Plaquenil. Paresthesias of all four extremities, a chronic finding. Cognitive dysfunction had been going on for about 2 years prior to presentation. Difficulty with reading, writing, word finding, and ataxia that had been attributed to gabapentin therapy after she had had an unremarkable MRI brain in 2013. That did actually get a little better off of gabapentin, but never resolved. Left knee, pigmented villonodular synovitis with a knee replacement, psoriasis, left breast ductal carcinoma in situ, hypertension, asthma, allergic rhinitis, hypercholesterolemia, and migraines. This is her list of medications. Social history, she was a never smoker. She did not drink any alcohol or use any drugs. She was a former secretary and was now retired. She has a sister who she lived with who had psoriatic arthritis, ulcerative colitis, and breast cancer as well. Her daughter had ulcerative colitis, and her mother also had breast cancer. So on physical exam, she had a fever of 103.5 with a pulse of 96. Blood pressure was 136/72. And she was saturating 92% on room air with 18 respirators per minute. She appeared ill and had minimal bilateral tear menisci and a dry mouth with reduced sublingual salivary pooling. She had no cervical or axillary lymphadenopathy and no nuchal rigidity. Her cardiovascular exam was normal with the exception of some very mild lower extremity pitting edema. She had mild bibasilar wheezing on her respiratory exam. Her abdomen did not have any abdominal tenderness, had normal bowel sounds, but you could palpate the spleen tip slightly below the costal margin. She had no active psoriatic plaques and no other rashes or notable skin findings. She had no synovitis on exam and no joint abnormalities or deformities. Neurological exam had normal muscle strength and sensation throughout, 2+ symmetric reflexes throughout, and normal cerebellar testing. So very briefly, running through the laboratories, she had a normal creatinine, a mild transaminitis, as you can see, bili of 1.7, albumin of 2.5 with a total protein of 5.5, and slightly elevated alk phos. Her urinalysis was unremarkable, no RBCs or protein. She had a very mild leukocytosis, some anemia, a little bit of borderline platelets, elevated ferritin, elevated LDH, elevated haptoglobin, and a reticulocyte count that was not elevated. There was a peripheral smear that showed atypical lymphocytes and smudge cells, negative peripheral flow cytometry on that peripheral smear, and she did not have schistocytes. There was a lot of infectious workup that went through. Blood and urine cultures were negative, hepatitis, HIV were negative, infectious diarrhea causes were negative, syphilis, babesia, many viral causes, all negative here. She did have a quantiferon gold that was indeterminate. She had a lumbar puncture, which had an unremarkable glucose and protein, lots of blood, and a couple WBCs, 4 WBCs to be specific, and her perineoplastic panel was run on this CSF and was negative. Additional workup included an ESR of 90. She had an ANA 1 to 640 speckled. An anti-mitochondrial antibody was positive, low complements, high cryoglobulin IgG and IgMs. Qualitative IgM was high, and her beta-2 microglobulin was high. Unremarkable inflammatory workup included ANCAs, smooth muscle antibodies, RFCCP, double-stranded DNA, cryoglobulin IgA, her CPK, and her quantitative IgG and IgA. She had several radiological studies as well, prominent HILA on her chest x-ray with possible adenopathy and mild congestive failure. Her right upper quadrant ultrasound showed hepatomegaly without evidence of any focal liver mass and without dilated bile ducts. She had a chest, abdomen, pelvis CAT scan that showed a splenic infarct and some perisplenic mesenteric stranding with diffuse thickening of the left adrenal gland as well. She had an enlarged main pulmonary artery consistent with underlying pulmonary arterial hypertension. An MRI brain showed no focal lesions, but did show some sinus disease with inspissated secretions or purulent material in one of her sinuses. And then she had a lower extremity Doppler ultrasound, which did show a superficial thrombus in the right cephalic vein, but she had no evidence of a deeper venous thrombosis. Additionally, had a TEE, which showed normal valves, no vegetation, EF of 65%, hyperdynamic left ventricle, a bone marrow biopsy that was hypercellular, and had a tri-lineage hematopoiesis and reactive lymphocytosis, but was otherwise unremarkable, and bilateral temporal artery biopsies, which were, again, unremarkable. And without further ado, Dr. Hussain, come up and speak.
Thank you. Yeah.
Good evening, everybody. Thank you, Braden. Can you hear me? So we have a pretty straightforward case, right? A Sjogren's patient with maybe 30 different things going on. So take a minute to look at this. This is my busiest slide. But what really stands out is a 65-year-old with primary Sjogren's with fever of unknown origin, a liver disease, and some autoimmune process. So keeping that in mind, we can organize our differential into these three elements: the Sjogren's, the fever, and the underlying liver disease. By definition, this patient has fever of unknown origin because the temperature was more than 101 on several occasions, duration more than 3 weeks, and a failure to reach the diagnosis despite, I'm sure, more than a week of inpatient investigations. This is my approach to FUO. So an extensive history and physical, which was done in our patient and did not yield any positive findings. Next, we move on to routine diagnostics like chemistries, x-rays, still no positive results, and advanced imaging, which will categorize our differential into three main categories: infection, malignancy, and autoimmune processes. Further invasive diagnostics like transesophageal echocardiogram, LP, and biopsies can help differentiate this further. Now, based on what is going on with this patient, this is my differential for the FUO. Infections, which compromise 30 to 40% of the etiology, TB, especially extrapulmonary, occult infections and abscesses, osteomyelitis, endocarditis, ehrlichiosis or anaplasmosis. Malignancies account for 20 to 30% of cases and include a lymphoma, leukemia, solid tumors, hepatocellular carcinoma, and metastatic liver disease. Under the autoimmune heading is Still's disease, giant cell arthritis, cryoglobulinemia, polyarthritis, granulomatous polyangiitis, and Takayasu's arthritis. I did put a few under miscellaneous, including drug fever, alcoholic hepatitis, and some endocrine conditions which can cause FUO. Briefly, this just demonstrates that infections was a primary cause of FUO in the early 1950s, and now in the 2000s, as you can see, 22% constitute connective tissue disease and is the leading cause of and diagnosis of FUO. Something to keep in mind. So how do we narrow our diagnosis? Moving on to the liver disease. So how can we develop a differential to the liver disease? This is my approach to liver disease. So once we have kind of established that common toxic agents like acetaminophen is not the causative agent, or infectious agents, we did a very extensive workup for infectious etiology in our patient, and that was essentially negative. Common genetic causes, which will be apparent, are ruled out. What is left is autoimmune diseases. And among the autoimmune diseases, we have primarily 4 categories, including autoimmune hepatitis, primary biliary cirrhosis, autoimmune cholangitis, primary sclerosing cholangitis, and a few overlap syndromes between them. But we can't forget that a patient has underlying Sjogren's. So what could be the unifying factor in a patient who has Sjogren's, liver disease, and fever? There are some liver diseases which happen to occur in Sjogren's. Some of them, as you can see, are the autoimmune diseases that we already mentioned and talked about. But there are some liver diseases which are, in addition to these autoimmune diseases, associated with Sjogren's syndrome. And here again, this is the autoimmune hepatitis and the primary biliary cirrhosis, common to both. We can also think about hepatitis C, non-alcoholic fatty liver disease, and macrophage activation syndrome. These are some other autoimmune diseases which need to be considered, including adult Still's disease, giant cell arthritis, cryoglobulinemia, the granulomatous hepatitis, and hemochromatosis. I had a few easy rule-outs. The patient obviously doesn't have a miscellaneous, an unknown, or other disease. We need to find out what's going on with this patient. So these are a few of my easy rule-outs. Osteomyelitis, I'm going to stop using that. Osteomyelitis, there was no, the cultures were negative. Imaging did not give any evidence of osteomyelitis. Ehrlichiosis and anaplasmosis is usually associated with severe leukopenias, has a more acute onset, so I could rule that out. In terms of malignancy, solid tumors, hepatocellular carcinomas, metastatic liver disease would have shown up on imaging, so we can rule that out. Autoimmune diseases, including polyarthritis nodosa, GPA, and Takayasu's, again, the clinical presentation is not consistent. The ANCAs are negative, so low on your differential, and I could rule that out. The patient does not have any history of alcohol intake, so that's there. Endocrine diseases like thyrotoxicosis, there would be some mention of a workup or the presentation, so I was able to rule that out. I had less rule-outs, easy rule-outs in the liver disease. Hep C virus, because we are told that the patient was checked and Hep C virus was negative, although there was no mention of the viral load, but we'll say that the Hep C virus was negative. Non-alcoholic fatty liver disease would have shown up on the ultrasound in terms of steatosis, increased echogenicity, and if you remember, the ultrasound was normal in this patient. The other diseases like granulomatous hepatitis, that needs to be considered. For example, sarcoidosis can have a presentation, but again, the imaging was not consistent with that. I will talk about some granulomatous hepatitis like primary biliary cirrhosis and tuberculosis. Hemochromatosis, the picture was not consistent with iron overload, so I could rule that out or just put it as a less likely differential. Finally, we come to this set of entities, and we've tried to narrow our differential on the basis of what's going on in this patient, and I will briefly go over most of these. I do believe there's always a way to get to the diagnosis, but hopefully we won't have to wait that long. So always think about drugs and drug toxicity. The patient is on certain medications that are associated with both fever and liver disease. For example, lisinopril, NSAIDs like idodolac. In terms of liver disease, rosuvastatin and amlodipine are known to cause liver disease. Again, there was no history of initiation of a new medication because this usually is seen within a few days, 7 to 10 days of initiating the agent, so less likely that we are dealing with drug toxicity. Tuberculosis, especially the extrapulmonary tuberculosis, can have a nonspecific presentation with fever, fatigue, and cognitive changes. The quantiferon gold was indeterminate, and that didn't help us either way. We can't rule it out, we can't rule it in. Plus, there was no evidence of disseminated disease, there was no radiographic evidence, and we have a set of serologies that I cannot explain on the basis of extrapulmonary TB, so again, a less likely differential. Occult infections in the elderly are common causes. Things like intra-abdominal abscesses or infective endocarditis can have a subacute course in the elderly. However, the extensive infectious workup was negative, We had cultures which were negative. Imaging was negative. We would have picked up abscesses, and the TE was negative as well. So I can safely rule out infective endocarditis. Moving on to malignancies, lymphoma, especially non-Hodgkin's lymphoma. Important consideration because 5 to 10% of patients with Sjogren's do have polyclonal B-cell proliferation and can present with FUO. In addition to the liver involvement, which we already know, the patient, I will point out, has an elevated LDH, a hypocomplementemia, and mixed cryoglobulinemia. All of these are consistent with lymphoma. But keep in mind, we usually have other things like weight loss, night sweats, lymphadenopathy in such cases. And there was no mention in our presentation. Also, the imaging was negative, your flow cytometry was negative, and the bone marrow biopsy being negative helps rule this out. Leukemias like chronic lymphocytic leukemia, again, we can have fatigue, non-specific things going on, the liver involvement. Our patient also has elevated LDH, a beta-2 microglobulin, and smudge cells due to atypical lymphocytes in the peripheral blood smear. Again, no lymphadenopathy, no hypogammaglobulinemias. Flow cytometry, importantly, was negative, and so was the bone marrow biopsy. So very low differential. Now comes the interesting giant cell arteritis. The age is appropriate. FUO is seen and could be high grade in up to 20% of the patients. Can present with fatigue and visual hallucinations. In addition to your liver involvement, elevated ESR, markedly elevated ESR and CRP are seen, and our patient has that. But I didn't get a sense that there was any change in the underlying migraine headache that the patient has. No new headaches were reported. There was no mention of temporal tenderness or jaw claudication, no visual changes, and the negative bilateral temporal artery biopsy helps, although it doesn't exactly exclude it, but again, we can put it one of the low differentials. Moving on to adult Still's disease. Can present with daily spiking fevers and the liver anomalies, but also keep in mind our patient had elevated ferritin. However, in adult Still's, the ferritin is usually more than 3,000. Our patient's ferritin is around 1,500, so not quite there. Elevated ESR and CRP seen in all patients, and the negative rheumatoid factor does support this diagnosis. The patient's age being 65, kind of unusual. There was no mention of evanescent rash, arthralgias that we see in these patients. And the ANA being positive is unusual because 90% of the patients with adult Stills are ANA negative. Was not one of my favorite diagnoses. Mixed cryoglobulinemia. An interesting diagnosis, onset around the 6th decade, can present with fatigue in 80% and paresthesias. Remember, our patient had these numbness, tingling in all the extremities, so could that explain it? Sickle symptoms seen in 30%, and we have an elevated cryocrit with polyclonal IgG, IgM. There are low complements, hypergammaglobulinemia, and association with Sjogren's is seen in up to 20% of the patients. However, clinically, it doesn't quite fit. There's no classic cutaneous manifestations like palpable purpura, no arthralgias or myalgias, no mention of renal disease, which is commonly seen in mixed cryoglobulinemia, and our patient was negative for Hep C and Hep B and HIV. And 90% of patients with mixed cryoglobulinemia are known to be Hep C positive. So not the diagnosis of choice. Next, we can talk about hemophagocytic lymphohistiocytosis, also called macrophage activation syndrome when it is associated with a rheumatological condition. This was really interesting. Again, FUO in 95% of the patients can have altered mental status because of the encephalitis, and our patient does have the elevated ferritin levels. However, clinically, you would expect a more acute presentation. There would be significant multi-organ involvement, which our patient does not have. And the bone marrow biopsy is unremarkable. There's negative flow cytometry and negative imaging. I do not have any information on the soluble CD25 level, so I cannot absolutely rule it out, but again, low on the differential. Moving on to the liver diseases. Autoimmune hepatitis. can present as a prolonged subclinical disease with hepatosplenomegaly. More importantly, in terms of the serology, can we explain this? The ANA being speckled is the most common serology associated with autoimmune hepatitis, and we have a positive antimitochondrial antibody in about 20% of the patients. It is associated with Sjogren's syndrome, but it's a rare association. Keep in mind, our patients' clinical picture, the liver involvement is cholestatic, and autoimmune hepatitis does not cause that. We have normal IgG levels. The serology also is not absolutely supportive because most patients with autoimmune hepatitis have a positive anti-smooth muscle antibody, and our patient had a negative anti-smooth muscle antibody. Also, the ANCAs were negative. So putting this together, this is not the diagnosis of choice, but it's a possibility. Primary sclerosing cholangitis can commonly present with fatigue. And in terms of fever, there's episodic bacterial cholangitis, which causes these episodic fevers. The pattern is cholestatic. A patient has that. We have elevated IgM and a positive ANA. But there are a lot of things clinically which don't fit. There's no pruritus, excoriations. No mention of ulcerative colitis, although if you remember, there was a family history of ulcerative colitis because it is commonly associated with that in 90% of the cases. Ultrasound being normal with no biliary dilatation, with no stenosis, essentially helped me rule this out because you would see that with PSC. So the next one, which was a very interesting diagnosis and differential, was primary biliary cirrhosis. Almost exclusively seen in females. Can present with fever, fatigue, commonly in 80% of the patients, some cognitive impairment, and Sjogren's syndrome is associated in up to half the patients. The involvement of the liver is a cholestatic pattern with an elevated alk phos and bilirubin and modest transaminitis. That's exactly what our patient had a mixed picture. So this fits. Our patient also had elevated IgM, hypercholesterolemia. In PBC, it's usually the HDL, which is elevated, low complements, elevated ESR, and more importantly, a positive antimitochondrial antibody, which is a serological hallmark of PBC, sensitivity 95% and specificity 98%. Also, 70% of the patients who have PBC have a positive ANA. So a lot of things which supported this diagnosis and not a whole lot against it. Maybe clinically the patient didn't have pruritus, right upper quadrant pain, or hyperpigmentation, but that anyways is present in less than 50% of the cases. So this is my diagnosis of choice. Now, what's the relationship between the Sjogren's and primary biliary cirrhosis? 3 to 9% of patients with primary Sjogren's have PBC. And most PBC patients, in fact, are identified as a result of extrahepatic autoimmune conditions rather than symptoms of liver disease. There was a very interesting study done by Scopoli in which they said that the liver involvement in Sjogren's patients is subclinical with histological features predominantly of PBC, and concluded that antimitochondrial antibody is the most sensitive indicator of underlying liver pathology in primary Sjogren's syndrome. I briefly want to talk about autoimmune cholangitis only because it's a PBC patient who is positive ANA but negative AMA, also called AMA negative PBC. Histology and outcomes are similar to primary biliary cirrhosis. Overlap syndromes are very confusing, but I just want you to look at the one that I've highlighted. It's autoimmune hepatitis and PBC overlap, seen in 7 to 15% of the cases. Serology of PBC, histology of autoimmune hepatitis, and the disease resembles PBC more closely. So we have narrowed our diagnosis, and this is my diagnosis of choice. PBC and or autoimmune hepatitis and PBC overlap. And there were other tests that I would have liked to order, like a soluble CD25 level to be able to exclude macrophage activation syndrome, because that was also a possible diagnosis. There was no mention of herpes simplex virus PCR. Maybe that was done, but I would have liked to know that because that can also be a multi-system presentation and high fevers, although more acute and not such a prolonged illness. A GGT level and a PT-INR to assess the extent of liver damage. So I rest my case, and this is my favorite diagnosis and the likely diagnosis. Primary biliary cirrhosis, autoimmune hepatitis with primary biliary cirrhosis overlap. And the more important question, I think, is what should be the next thing to do to diagnose what this patient has? And I firmly believe that we should get a liver biopsy in this patient. Not because I have multiple reasons to get this. One of them being the patient has FUO. We still haven't figured out what is the cause, so I would get a liver biopsy. The other reason is the high ferritin, and I don't know why that's going on. The patient has a liver disease with Sjogren's. I would like to get a liver biopsy. And the fact that we have a positive antimitochondrial antibody with a normal ultrasound, again, directs me to get a liver biopsy. So irrespective of what comes out of it, I would definitely get a liver biopsy. And if you still have any questions about the diagnosis, please don't hesitate. Thank you.
That was outstanding differential. Glad you took us through the case. All right, so Braden, can you tell us what happened?
So unlike that client, I will give you the answer. We did get a liver biopsy, actually two. The first liver biopsy was undiagnostic, but with continued symptoms, the second liver biopsy gave the following results. Atypical lymphoid infiltrate, and in some areas this infiltrate was restricted to the portal tracts, while other areas showed complete architectural effacement. The infiltrate contained numerous large atypical lymphocytes, oval and irregular nuclei with those, vesicular chromatin, single and occasional prominent nucleoli, and moderately abundant cytoplasm. Flow cytometry showed discrete populations of large surface lambda-restricted CD5 positive, CD10 negative, CD19 positive B cells. So this was diagnostic of a CD5 positive diffuse large B-cell lymphoma with high-grade features. So I wanted to talk about the malignancy risk in primary Sjogren's. There's a meta-analysis that I reviewed of 14 studies involving about 14,500 patients with primary Sjogren's. This included centers from Asia, Europe, and the United States. It evaluated a pool of relative risks for the development of various malignancies, and then applied statistical techniques for meta-analysis to confirm or deny whether these were statistically significant. This is a very busy slide, but I tried to highlight the areas of interest, particularly non-Hodgkin's lymphoma, 11 different studies, quite a high pooled relative risk of 13.76. Myeloma was elevated at 4.67, and then thyroid cancer at 2.58, and leukemia at 3.6. We'll review these further here. So first, non-Hodgkin's lymphoma, the one we all think about when we think of primary Sjogren's. The association of increased risk was only actually confirmed in European populations, and data in Asian and American populations was not sufficient enough or plentiful enough to actually confirm this association. The relative risk is much higher in hospital-based studies as compared to population-based studies. As you might imagine, those patients could be more sick and have more extraglandular manifestations of Sjogren's. The relative risk is also much higher in populations who were followed for longer periods of time. So when you follow people for longer than 6.9 years, you would see a much higher relative risk of developing non-Hodgkin's lymphoma. There was no strong data to suggest a mean age at which this lymphoma would develop, though there was a lot of these studies that didn't really comment on age. And only one study addressed the non-Hodgkin's lymphoma risk in men, and there was actually no associated increased risk in this one study. The risk for developing other malignancies. So despite a noted increase in relative risk for developing myeloma, the statistical analysis of this data actually yielded results suggesting that there was no increased risk for myeloma. There is, however, an increased risk, or what they think to be an increased risk for thyroid cancer. but its inclusion in only 2 studies begs for more studies to really confirm this assertion. It also remains unclear if the noted 53% overall increased risk for malignancy observed is due primarily to just non-Hodgkin's lymphoma, or if other solid malignancies that they didn't pick up on play a role in that. Other confounding factors in this study that were generally not addressed in this meta-analysis were things like BMI, alcohol consumption, tobacco use, and most interestingly, I think, the use and type of immunosuppressive therapy used to control Sjogren's. So what are the predictors for lymphoma development, specifically non-Hodgkin's lymphoma? I reviewed another systemic review and meta-analysis of 18 cohort studies, again, including about 15,000 patients. As you might imagine, 90% of these were female. And in this meta-analysis, they reviewed existing empirical evidence for clinical and for laboratory findings that might be predictive of lymphoma onset amongst primary Sjogren's syndrome. So what we care about as clinicians when we're following Sjogren's patients. Most of the patients in these studies met the diagnosis of Sjogren's by the American-European consensus criteria. The lymphoma diagnoses were tissue diagnoses and based upon histological findings, and non-Hodgkin's were the most frequently reported. So the risk for developing lymphoma varies with the time after the diagnosis. So within the first 5 years, about 4% of people will go on to get lymphoma, and then this increases as we go to 15 years and then past 20 years up to 18%. So clinical findings that we need to pay attention to: parotid enlargement. This is considered predictive of development of lymphoproliferative disorders in 6 different studies from this meta-analysis, though they only reached statistical significance in 3 of these studies. It's been proposed actually as a marker for Sjogren's patients with significant lymphoid reactivity to have inflamed parotid glands. And this may even be a likely independent risk factor for the development of lymphoma in its own right. Parotid scintigraphy has even been postulated as an independent risk factor for identifying primary Sjogren's patients that are at a high risk of developing extraglandular manifestations, irregardless of whether they'll go on to develop lymphoma or not. Other important clinical findings: lymphadenopathy, the only risk factor that was found to be a statistically significant predictor of malignancy in every single study that examined it. And palpable purpura has a significant association with lymphoma in 6 studies, though actually only 1 of these demonstrated statistical significance as an independent risk factor. Splenomegaly was examined in 3 articles, but only 1 found it to be a risk factor for lymphoma, though a second study found it as a risk factor for increased mortality. They weren't sure of the cause there. Skin ulcers were noted in 1 small study as well that found an association with lymphoma development with a very high odds ratio of 21.7. And this is just another busy slide going over all the studies that were included and the relative risk-hazard ratios, et cetera, with parotid enlargement, lymphadenopathy, and palpable purpura having the most positive predictive findings. What about laboratory findings? Hypocomplementemia, so low C3, less than 0.82 grams per liter, was found to be an independent risk factor, but 4 other studies failed to note this association. However, more importantly, low C4 levels were identified as a strong predictor of future lymphoma development in 7 out of 8 studies. Additionally, low C4 has been noted to be helpful as a prognostic marker for survival. There was actually another study with a cohort of 244 patients followed at a University Sjogren's Center. They followed this respectively, and 2 out of the 3 patients they had who eventually died from lymphoma had very low C3, C4 levels at their initial diagnosis of Sjogren's. Low C3 and C4 levels at the time of diagnosis appear to be predictive of early development of non-Hodgkin's lymphoma, so within the first 5 years after the diagnosis is made. Other important laboratory findings include lymphocytopenia, which is a strong and independent risk factor, and in particular has a significant association between CD4 positive T-cell lymphopenia and the development of non-Hodgkin's lymphoma. And this was detected in 80% of the studies that actually reviewed this parameter. Additionally, low CD4 positive to CD8 positive T-cell ratio, so a ratio less than 0.8, was very predictive of developing lymphoma. Cryoglobulinemia was examined in 8 studies, but found to have a significant association with the development of lymphoproliferative disorders in 4 of these studies. Anti-Ro and anti-LA antibodies were examined in 6, but only found to be important in 1 study. And factors that had no association with lymphoproliferative disorders included anemia, ANA, RF, hypergammaglobulinemia, and there actually was not enough data to analyze anything regarding male gender as a risk factor. And this, again, is another busy slide here, highlighting that low complementemia, particularly low C4, cryoglobulinemia, and lymphopenia are very important predictors of future development for lymphoma. Interestingly, the presence of more than one of these clinical or serological risk factors further raises the possibility of developing a malignant process. And there is a distinct absence of data regarding the impact of DMARD therapy and biological treatments as they relate to the future development of malignancy. I think this is an area where we could improve our data. Just briefly, Leonidas and colleagues suggested classifying Sjogren's patients as either type 1 or type 2 at the initial time of diagnosis, type 1 being no low C4, no palpable purpura on presentation, indicating a low risk for malignancy, whereas type 2 would have a very low C4 or palpable purpura on presentation, indicating a high risk for malignancy. And many experts recommend the following frequent screening when you have a Sjogren's patient. So obviously clinical evaluation is important, CBC, looking for lymphopenia specifically, complements, cryos, and an SPEP. So these are things we should be following regularly in our Sjogren's patients, particularly the ones we're worried about who may have higher risk factors for developing lymphoma. And I'll just skip over that and tell you about the patient. So she was transferred to the liquid oncology service at HUP and eventually developed a clinical picture consistent with HLH, as we were discussing earlier, with ferritin levels peaking at about 33,000. She got R-EPOCH chemotherapy but developed severe mucositis with concerns for airway compromise. So a change was made in her regimen to R-CHOP chemotherapy, and she got 5 more cycles, so a total of 6 cycles of chemotherapy with resolution of fevers after the initiation of chemotherapy. She also received high-dose methotrexate for prophylaxis against CNS lymphoma, and there are plans to do 3 more cycles of that. She continues to have episodes of short-term memory difficulties, but the altered mental status has improved somewhat. And they've had extensive neurological workup for her, and the workup still remains negative. Thank you.
Well, I'd like to admit that that was really a challenging case, and then we went in, we wanted a liver biopsy, looking for a liver disease, actually. Having a negative bone marrow biopsy and flow cytometry made it even more complexing, and I can only imagine, you know, the difficulty facing this. So, but I think the differential diagnosis you came up with, it was amazing. It was well thought of, and it was, you know, similar to what we went through. So, thank you for going through the differential diagnosis. All right, so our next case, it's going to be a case of polyarthritis and painful skin nodules. So I'm going to ask Maria to come up and introduce the case. Maria, I'm going to ask you to really take no more than 5 minutes to present the case.
That's 10 minutes.
All right, Joe, 5 minutes.
Good evening, everyone. This is about a 55-year-old man with painful nodules on his shin and polyarthritis. So 55-year-old Caucasian male presented to our hospital with 1-week history of severe pain and swelling of his left knee. 3 days later, he developed right knee and bilateral ankle pain, swelling, and redness. Over-the-counter NSAIDs provided no relief. The pain was so incapacitating that warranted him an ER admission. 3 months prior to his symptoms, he visited Wyoming for skiing. Upon his return, he started noticing painful nodules on both thighs and pretibial areas. His past medical history was significant for dyslipidemia and hypertension. Medication-wise, he was taking HCTZ and atorvastatin. Past surgical history was unremarkable. Family history was unremarkable for any autoimmune disease or any malignancy. He did not have any allergies. He was a contractor by profession. He denied tobacco, alcohol, or any illicit drug use. He lived with his wife and daughter. Review of system was only positive for generalized fatigue for a few months. The rest of the review of system was negative. He denied any history of trauma. On physical exam, the vital signs were stable. He had multiple erythematous tender nodules, 2 millimeters in diameter on bilateral shin and thighs. His knees and ankles were warm, swollen, and tender bilaterally. Range of motion of knees and ankles was limited, secondary to pain and swelling. DIP, PIP, MCP, wrists, elbows, shoulders, and hips showed no effusion, tenderness, warmth, or erythema with normal range of motion. Rest of the exam was within normal limits. Initial lab tests were done that included a normal CBC. CAM7 was normal. Urine analysis showed no protein or no blood. Urine culture was negative. Blood cultures were negative. Synovial fluid analysis showed RBC count of 6,900, WBC count of only 244, negative gram stain, negative for cultures, and negative for crystals. Seemed like a traumatic tap. Further tests were performed that showed an alanine aminotransferase, ALT, of 114, AST of 127, those were both high, alkaline phosphatase of 197, which was also high, a CPK of 100, Hep B and C were negative, TB quantiferon was negative, AS level was normal, ANA was negative, ANCA was negative, and rheumatoid factor was also negative. Imaging studies were done that included a chest X-ray that showed no lymphadenopathy or any parenchymal disease. X-ray of the knees and ankles were performed that showed soft tissue swelling. Joint space was maintained with no fractures or any dislocation. So what were these painful lesions? Let's biopsy them. Biopsy showed superficial and deep dermis with mild fibrosis and mixed perivascular infiltrate. Subcutaneous lobules demonstrated ghost cells characterized by anucleated cells with amorphic basophilic debris. There was no vasculitis seen. Cultures were negative for bacteria, fungi, or AFP. There were no atypical cells consistent with lymphoma. In the interim, the patient was treated with pain medications and steroids empirically. A crucial diagnostic blood test was performed. I'd like to invite Dr. Gonzalez.
Good evening. All right, so she just presented the case, but I just wanted to highlight sort of a summary of the case. Patient, 55 years old, had a several month history of fatigue, 1 week history of arthritis affecting the knees and ankles, 3 months of erythematous painful nodules at his lower extremities. He had traveled to Wyoming before the lesions appeared. His medications were atorvastatin and hydrochlorothiazide. He works as a contractor. Laboratories were only significant for elevated liver function tests. The synovial fluid was revealed a non-inflammatory effusion, and the biopsy of the skin lesions was consistent with lobular paniculitis with ghost cells with no vasculitis. So, where do we start? So, taking into consideration the salient features of the case, polyarthritis and paniculitis, I made my list of the differential diagnosis, and I divided it between infectious, inflammatory or rheumatologic causes, malignancy, and a miscellaneous or others category. The patient had no symptoms of an upper respiratory tract infection, no respiratory symptoms at all. The lesions were going on for 3 months, so it seems more of a chronic nature. So I took away the possibility of strep pharyngitis or chlamydia pneumonia. The patient was a contractor. We don't know about his travel history other than he had gone to Wyoming. And none of these infections, coccidio, blasto, histo, or leprosy, are endemic to Wyoming. So I took out those from the differential. Hepatitis B and C were negative. He had negative quantiferon gold, and the AFB staining for the skin biopsy were negative. Patient had no reported blood in stools, diarrhea, oral or genital ulcers. So I took away from my list inflammatory bowel disease, Behçet's, and possibly celiac disease. The patient had a polyarthritis, but was non-inflammatory, no mention of crystals in the synovial fluid, no tophi and physical exam, no radiographic changes suggestive of gout. So I took away gout because it can actually cause a paniculitis with the position of the crystals in the skin. The patient had a negative ANA. Actually, the patient had no weakness on physical exam, normal CK levels, so I took away dermatomyositis. Negative ANA with no Raynaud's, no GERD, no skin thickening mentioned on the physical exam, taking away from my differential scleroderma and autoimmune hepatitis. Not taking away lupus from the differential diagnosis because despite having a negative ANA, there's an entity called lupus paniculitis or lupus profundus, and patients could potentially have a negative ANA. So I'm just going to leave it on my list for now. So now that I narrowed down my list to about 10 possibilities, I decided to go more into the skin biopsy. The biopsy suggested a lobular paniculitis, noting the lobular part with ghost cells, and there was no vasculitis on the biopsy. Paniculitis, I don't want to go too much into discussing a diagnosis, right? But paniculitis basically is a heterogeneous group of inflammatory disorders that are characterized by inflammatory infiltrate in the subcutaneous fat layer of, in the subcutaneous fat. They are divided according histologically where the inflammation is occurring, either septal or lobular, and within those there could be vasculitis findings in the biopsy or not. So the biopsy that we had mentioned that it was lobular, so I'm going to take away everything that possibly can cause a septal paniculitis. From those, I am going to take away sarcoidosis. The patient had a negative chest x-ray that had no lymphadenopathy. The paniculitis that can occur in sarcoidosis is typically erythema nodosum, and that's typically more of a septal paniculitis. Polyarteritis nodosa, I had left it in the list despite a negative ANCA and normal urinalysis because you can have negative ANCAs and have polyarteritis nodosa, and you can also only have cutaneous involvement. But his biopsy did not suggest any features of vasculitis, and it was more of a septal polyarteritis nodosa can cause a septal paniculitis. With rheumatoid arthritis, we can have rheumatoid nodules, which actually are considered a septal paniculitis. The patient had a negative rheumatoid factor, no X-ray findings of rheumatoid arthritis, and the arthritis was non-inflammatory, taking away rheumatoid arthritis. So now my list is a little bit shorter, but still I have a few things to consider. What about these ghost cells? Is this the key to the case? And I think so. So ghost cells are actually adipocytes that have lost their nucleus and have a shadowy cell membrane that is thought to be occurring because of a process of digestion. What is causing the digestion of that cell membrane? It's supposed to be saponification by the hydrolytic action of pancreatic enzymes. The combination of ghost cells in a biopsy with lobular paniculitis is pretty pathognomonic for pancreatic paniculitis. And the arthritis could be explained because the same process can occur in the periarticular fat. So the patients can actually have polyarthritis secondary to this. Within pancreatic panniculitis, there are several causes, possible causes, but the most frequent are acute or chronic pancreatitis and or pancreatic carcinoma. So if I needed to distinguish between the two, I'm going to go a little bit more into that. And I would say that the clinical picture is actually not suggestive of acute pancreatitis. There was lack of pain. The patient's symptoms were going on for almost 3 months. He did not have a history of acute pancreatitis in the past that would suggest that he has chronic pancreatitis. He's not a reported alcohol drinker, no history of gallstones. The onset has been very, very insidious. So all of those factors make me sway more towards pancreatic cancer as a diagnosis. The lack of pain and the lack of jaundice does not rule out pancreatic cancer because the development of jaundice actually depends on the location of the tumor. So if I have to be pressed for an answer in terms of what blood test I would order, I guess I would order all of these, but the serum CA19-9 could be very helpful when you have a pretest possibility or thinking of pancreatic cancer, but in acute pancreatitis, you can actually have elevated levels of serum CA19-9. But I would say that that's what I would order, serum CA19-9, and I'll order an ultrasound or abdominal CT scan to get the diagnosis. And
All right, so Mariah. Mariah will tell us what the patient was diagnosed with.
Okay, so what's the diagnostic blood test that give us the clue? That was the serum lipase level. It was very elevated, 7,733. Amylase was 118. Based on high amylase and lipase, a CAT scan abdomen and pelvis was performed to rule out pancreatic pathology. CT scan of the abdomen and pelvis showed 3 by 1.1 centimeter pancreatic mass in the uncinate process with metastasis to the liver. The largest mass was in the liver dome at the border of right and left lobes, measuring 4.8 by 4.7 centimeters, and contained internal fluid signal consistent with necrosis. Further tests were performed that included a normal CEA level 1.9, CA19.9 was also normal, which was 27. Pancreatic polypeptide was normal, 733. Chromogranin, GI tumor marker, alpha-fetoprotein was also normal, and alpha-1 antitrypsin levels were also normal. Biopsy of that pancreatic mass was performed. Endoscopic guided pancreatic biopsy was performed. That showed insufficient tissue, hence an ultrasound guided liver biopsy had to be performed. That showed metastatic adenocarcinoma consistent with pancreatic acinar cell carcinoma. So what was the diagnosis? Dr. Gonzalez correctly pointed out. Pancreatic panniculitis and polyarthritis, PPP syndrome. I think she went through the differential diagnosis very well, including erythema nodosum, lupus panniculitis, cutaneous polyarthritis nodosa, erythema induratum, lipodermatosclerosis. So I'm going to skip these slides. Infection was also ruled out based on negative blood cultures and negative cultures of the panniculitis. Trauma, cutaneous lymphoma, and alpha-1 antitrypsin deficiency was also ruled out pretty well. So I'm going to talk a little bit about pancreatic panniculitis and polyarthritis. Pancreatic panniculitis is a rare entity occurring in less than 2% of patients with pancreatic disorders. It is associated with acute or chronic pancreatitis, pancreas divisum, pancreatic pseudocyst, and pancreatic carcinoma, in particular acinar cell cancer, as in this case. Clinically, patients with pancreatic panniculitis most often present with disseminated, ill-defined tender, erythematous, and violaceous nodules in the decubitus areas and lower extremities. Joint pain and swelling is another common symptom, as in our case. The joint symptoms do not correlate with primary synovitis, but it is caused by periarticular fat necrosis, and hence the synovial fluid analysis showed a non-inflammatory synovial fluid analysis. The synovial fluid analysis may demonstrate lipid crystals with Maltese cross appearance. It is believed that arthropathy or arthritis is associated with poor prognosis. The panniculitis probably result from local action of blood-borne pancreatic lipase and trypsin. Clinical appearance is nonspecific, and it mimics erythema nodosum, panniculitis-like subcutaneous lymphoma, and alpha-1 antitrypsin deficiency panniculitis. Therefore, the diagnosis usually requires further investigations, conventional radiological imaging of the pancreas and the involved joints, detailed lab examinations such as assessing the pancreatic enzymes and tumoral markers, and a biopsy of the skin lesions are required. Biopsy specimen from lesions of pancreatic panniculitis show anucleated adipocytes with a thickened shadowy wall and granular basophilic cytoplasm, and these are called ghost-like cells, as demonstrated in our case. This was a case of pancreatic panniculitis associated with SNR cell carcinoma of the pancreas, which accounts for only 1 to 2% of all exocrine pancreatic neoplasms. SNR cell carcinoma is a kind of functional exocrine tumor that is characterized by an increased level of serum lipase, leading to paraneoplastic syndrome. Often abdominal symptoms and constitutional symptoms are absent, as in our case, which leads to misdiagnosis or a delay in diagnosis. So, checking a lipase level in these patients with panniculitis and polyarthritis leads to a diagnostic clue. Treatment of pancreatic panniculitis, polyarthritis should be directed at the underlying pancreatic diseases. Octreotide, NSAIDs, and steroids have been used to treat symptoms only transiently. So back to the case. The patient was discharged on steroid taper to be followed by oncology as outpatient. He decided he will follow up with oncology closer to his home, and hence he was lost to follow up with us. My literature review from PubMed identified around 30 well-documented cases of complete PPP syndrome associated with pancreatic carcinoma. Given that the diagnosis is often difficult when abdominal symptoms are absent, knowledge of the association between panniculitis and polyarthritis with pancreatic disease may lead to a prompt diagnosis and management. Thank you very much.
I'd like to thank both of our fellows and both of our speakers. They both did a wonderful job. I think the most essential part of this exercise is to go through the differential diagnosis and then to present the thought process so we can, as we think about those cases, we can learn a little bit more about the field of rheumatology. So on behalf of the Philadelphia Rheumatism Society, I'd like to thank you for your presence. I'd like to thank the pharmaceutical companies for their support, and hopefully we'll see you sometime next week. I don't know, Dr. Udell, do you have any closing comments?
Thank everyone for coming. The participants, I think we need to take a picture of everyone for the website. Otherwise, we'll see you in April.
All right. Wonderful. Well, have a nice evening, everybody.